They say knowledge is power, but you need the wisdom to understand what this actually means. Welcome to the Decoding Health Podcast. I am your host, Dr. Urban A. Kiernan. Each week, we will share the stage with renowned experts as we dismantle the black box of knowledge and unravel the complexities of science and its practical applications in our daily life. This show is committed to illuminating topics ranging from personal health and wellness to cutting-edge biopharmaceutical advancements and beyond. Let's get started. Hey, Dr. Nadler. Evan, welcome to the Decoding Health Podcast. Really fortunate for, thank you very much for sharing your time, with us. Let's kind of get started on this. How did you end up getting into medicine and then specializing in, childhood and adolescent obesity and weight loss?
Well, first, thanks for having me, Urban. Really appreciate it. Always happy to chat about childhood obesity because it's sort of my passion. Well, it is my passion. It's not sort of my passion. And it's become almost like a mission for me to try to educate the world about this particular disease. So how did I get into medicine? That's actually a longer story, but it starts from me being a dope and jumping off a bunk bed when I was 6 and landing on my elbow and shattering my elbow and going to see an orthopedic surgeon who took care of me and helped me. And I'd like to think I learned, it's probably not a great story to share when I'm taking care of patients to know that my judgment was so poor at age 6, but hopefully I've learned something since then, so I'm not making the same mistakes now. But that was the beginning of the story. And then fast forward to medical school, I was actually interested in being an orthopedic surgeon myself because of that experience with my injury at age 6, but then got sort of bitten by the saving lives bug and became interested in thoracic surgery, actually, heart surgery, chest surgery, lung surgery, and then pediatric surgery after that because I like taking care of the little kids. And no one goes into pediatric surgery thinking that they're going to be a childhood obesity expert. Like, we go into it to take care of newborns that have congenital problems or get sick as preemies or something like that. But I just had an epiphany about 20 years ago, sitting at a pool in Orlando over Memorial Day at a medical meeting, actually, and just looking around the pool and seeing the kids and the adults. And I just was like, wow, somebody really needs to take this disease on, and especially for kids. And, I think who better than me? So that was actually maybe almost 25 years ago now. And then basically started doing bariatric surgery on kids about 20 years ago, which you can imagine was sort of unheard of at the time, and dealt with a lot of what we would call in today's lingo trolls or haters or whatever. Lots of people along the way thought I was crazy or a monster or both, and some may still feel that way. So fast forward 20 years, I'm sort of the world's expert in this. And in large part, it was because I just looked at the problem, learned about the science, read about the science. And while treating patients along the way, I've had research grants for clinical science, for translational science, for basic science, learning about fat cells and what they do. And so I feel like I have sort of a comprehensive, or at least a 360 view of the disease that many maybe don't have, just because I sort of looked at it from a bunch of different angles. And I think, I keep saying the word disease because I think the point, maybe the major take-home point, is that it is a disease. obesity, especially childhood obesity. And so that's like the number one thing I've learned over time. And I think that's sort of the message I'm still trying to get out there as much as possible, because there are plenty of folks who just still think it's just about, lack of exercise and a poor diet. And that's actually, far from true.
And then you're bringing forward some very interesting and very relevant points, especially the way the Western healthcare system is set up. And like, yeah, there is an ICD-10 code for obesity, but it's not a reimbursable ICD-10 code. Like, I need you to be sicker other than meeting the clinical definition of obesity. And so let's kind of like begin there, because like a lot of people use like BMI as the definition of obesity, and that's a very flawed number in reality. You, as somebody who's a world's expert, like, what do you define as obesity?
Yeah. So first of all, great point about BMI. BMI is a screening tool. It's just a starting point for us to like say, your height and weight suggests that you might have medical issues related to your weight. And you probably know, since you knew the ICD-10 codes that weren't reimbursable, which is very impressive. I'm very impressed that you know that. But BMI. So in people of Southeast Asian descent, for instance, they might get diabetes at a BMI of 28. Whereas in Western cultures, you might not get diabetes, or I shouldn't even say Western cultures. Caucasians may not get diabetes until a BMI of 35. So, so the number itself is just a starting point. So the question was, how do I define obesity? And I define it really as if your weight negatively impacts your physical or your mental health, then that to me is something worth treating. And it doesn't matter necessarily if you meet some arbitrary threshold that insurance providers or somebody else has created. And obviously it's harder to get things approved by insurance companies, for instance, if you don't meet those thresholds. And I'm not saying that everybody who is unhappy with their weight should get on a GLP-1 medication just so that they, I'm not suggesting that everybody who has just a little bit of weight to lose or is unhappy with their weight get on a GLP-1 medication just so that they can look better and feel better about themselves. Although, frankly, one could argue that that's enough. But I am saying that if your weight is negatively impacting your life, there are multiple different ways that people can start to address that. And that to me would be the time to, talk to a provider or start to look into things about what you can do. And those things run the gamut from lifestyle changes to surgery and everything in between. And so I've always just consider myself somewhat of a treatment agnostic, meaning I don't really, while I'm a pediatric surgeon, I've done bariatric surgery on more kids than anybody in the country. I also know that's not right for everybody. And I also know that that's not scalable, right? I can't operate on the 15 million children all who have obesity. So the other pieces of the puzzle, the other, arrows in the quiver or tools in the toolbox or whatever analogy you want to use, that they all are important and they all need to be, used by different people at different times.
And so this is, very interesting to me, because I'm almost seeing like it's a decision tree type aspect, and then you and your ultimate skill set, even though you're agnostic regarding treatment. Like, as long as you get better, with your Hippocratic oath, as long as you get better, that's all what we care about. But before somebody goes and ends up on your OR table, do they have to follow, like, we've tried this, and we've tried, and it's like, no, no. And then finally, you are like the last resort, or can you be frontline when it comes to this?
Yeah. So yes and no. So first of all, no one, at least in my 20 years, no one has come to my office and been like, yeah, we don't want to try anything else. We're not going to try anything else. We just want surgery. Like no one in their head, that's no one's first choice. Like I'm just going to go get surgery because I don't even feel like eating, fewer snacks or whatever, not drinking soda, whatever it is. But there are actually occasions where I would tell people that surgery sooner rather than later is actually going to be better for them, and that they shouldn't go through all those different sort of iterations. Like you don't have to spend 6 months doing lifestyle changes and then 6 months on medications before you get to surgery, depending on certain things. Like, for instance, there are certain genetic defects that drastically increase the risk of childhood obesity. And if you have one of those defects, the likelihood of you succeeding with just lifestyle changes is almost nil. And even sometimes when we use meds in patients like that, it's more for weight stabilization than for weight loss. So there are some nuances to it. And it's not always some of the severe genetic conditions that can work that way. There are also other genes that more and more that are being identified that contribute and may contribute to different degrees. So in general, childhood obesity. Sorry about that. In general, childhood obesity is a disease that's more genetic and epigenetically driven, which probably makes sense intuitively, because if you're already struggling at age 8 or 9 with weight, and that means you've only really been in charge of your own diet for maybe 3 or 4 years, it's hard to imagine that your diet is what puts you in that situation. And so some of it's what are the genes we know, some of the genes that are being discovered all the time, and then the whole field of epigenetics, which is newer and I think not as well understood, is probably where the environment and genes come together to confer risk. And what I think people don't necessarily understand is that those epigenetically modified genes can get passed down from generation to generation as well. So even if you're a parent, a mom or a dad, before you're a mom or a dad, and you have some environmental changes to your genes that predispose to weight gain, you can pass it on to your kid. So it's not only the kid's behavior, but it's actually the parents' or the would-be parents' behavior that can actually make a big difference. And I think that's where I think we miss that a lot. Like I think the whole food is medicine movement that is doing some good in terms of changing food quality in the United States and some of the other ultra-processed food issues. But what people don't understand is that even those changes are probably going to take 2 generations before they actually manifest in like significant decreases in obesity rates. So.
No, agreed. And like, even like the whole concept of, knowledge, because like I'm a PhD. Everybody knows that, who watches the show. I'm fully transparent on that. I'm also in the drug space. I own my own drug company. The stuff that we're seeing in the R&D space is very different than what you guys practice in medicine. And there's a gap. There's this huge gap, and it's decades. Like I'm old enough to remember when HbA1c finally became a diagnostic, and I was actually in a meeting with some people at Johnson and Johnson, and they wanted my opinion regarding the value of it as a diagnostic. And I'm very frank and transparent, so I kind of told them, what it was. I think there's better things to be using than HB. I think HbA1c, you're a little late to the game when it comes to diagnosis, you know, but
Doesn't seem they didn't take your advice. Everybody uses A1C now. What happened?
no, I'm just one voice of everything, and there's
I'm
so many.
teasing.
Yeah, no,
I'm obviously teasing.
but I want to bring this up because we were talking about semantics. Beforehand, it's just scientific semantics is real and it's used to push agendas. There's politics everywhere. It's the business of science, and it's hard to turn around and just fundamentally make changes when you're going up against an institution. And that's what you're talking about right here. You're going up against the food industry. Everybody knows, there's none of this stuff that comes out where it's like, we've never known. We've all known this for forever. And the whole thing regarding eggs, it's finally the guidance has changed regarding the FDA that, oh yeah, you can eat the entire egg. It's actually beneficial to you. And at least in my world, that's been common knowledge for 20 years. It's like, I'm going to use the phrase, no shit, Sherlock. It's like, guess what? It's,
No, I often say that the egg lobby, they had the worst lobbyists ever because they got dumped on. The egg people got dumped on for really ever for 20, 30, 40 years now. And the evidence behind it just wasn't really there. And it's just taken a long time. Even now, I think it's still a lot of people, even I find myself actually, sometimes I have to remind myself that yes, it's okay. Actually, if you eat a whole egg, and even if you eat one more than once a week, it's actually okay. Like you're not going to, immediately have a heart attack from cholesterol. Yeah, no, it's unfortunate in that, yeah, everything obviously in today's world is even more politicized than it used to be. But there have always been agendas, and there's always, I'm not a conspiracy theorist, so I don't actually think that the food industry and big pharma are in cahoots to try to make the world fatter so that we can just treat everybody with new medications. I don't believe that. There are people who do. But I do think that the food industry's agenda is to make money and sell food, and the pharma's agenda is to make drugs that make people better, but also that make them a lot of money. So, it isn't, it's a complicated problem. And as you said before, sort of educating people about the ills of some foods, I think, people talk about bettering education. And I often will reply, who eats a bag of Doritos and thinks it's good for them? Does anybody actually grab a bag of chips or whatever without knowing that it's not nutritional or not good for them? And my answer is no. Everybody knows that. We just do it anyway. And is it because of brain chemistry that's been messed with over time, or genetics because or epigenetics because our parents did that? I don't know. But it's going to take more than education, I guess is my point. It's going to actually take some real work for us to turn this thing around.
And you bring up a good point. And one of my newer philosophies now is that the whole point of knowledge is action, not knowledge. And we're living in this crossroads right now, and it's really hard, at least the way through my looking glass that I see, in order to be able to take appropriate action, even though we have the knowledge. But with that said, back to the patient aspect, and being able to take action, especially when you have something that isn't a reimbursable diagnosis, because medicine is a business. It's, you have to make money, and not to sit there and say there's an intent to go and make people sicker, but it's just there's the economics behind the whole thing, in which, okay, I can go and prescribe you this, but your insurance isn't going to cover it. Can you afford $1,000 a month for said treatment? Yes or no? Because if the answer is no, then we got to move on to something else. That's just the fact of it. And then you've got other people who they could afford, they don't view it as enough of a problem. It's almost like cognitive dissonance regarding it. It's just like, oh, my parents were big boned. I'm big boned. My kids are big boned. That's just the way we are. And it's like, I'm not fat shaming anybody, but it's like, no, you guys are obese. You're not big boned. I'm going to call it out for what it is. You, as somebody who's in the space dealing with it, like, how much did you see of that? Because my wife is in the clinical space and she sees this like all the time, like especially in pediatrics, because these kids, as you already stated, they're not going to make meals for themselves. They're 7, 8 years old. It's up to the parents, but the parents aren't respecting the issue. Like, as a
So it's
clinician,
interesting. Obviously, as a bariatric surgeon or a pediatric bariatric surgeon, I saw a unique subset of patients, right? I saw patients who either found me or referred to me. And the ones who found me were usually, especially in the very beginning, were parents who had realized their own medical issues, done something about it, and then didn't want their kid to have to live through what they lived through. So like in the very beginning, when I started doing this 20 years ago, a lot of my patients were the kids of parents who'd had bariatric surgery. And like the parent would go online just searching bariatric surgery for children, and my name would come up because I'm like one of the only people who was doing it back then, just because they were desperate and they just saw their kid about, living the same life that they lived. So that group definitely understood the ills or the perils of excess weight. But then there'd be others who definitely didn't quite get their act together early on. Like it took some, it might have taken their kid to get a diagnosis of diabetes or something else before they really realized how big the problem was. So yeah, I mean, that is where I think education or like almost, like a mass education campaign could be helpful. And that's basically what I'm trying to do, which is, and because we talked about sort of the intergenerational transmission of obesity, not in those terms, but we sort of talked about genetics and epigenetics, which are huge parts of that. I really think that if I could target one group, it would be like young adults before they get married and before they have kids, and tell them, listen, here's your opportunity to help your child, the child that you don't have yet, but get your own metabolic health optimized before you have kids. And not only and do it whichever way you need to, but not only will that help your kid from a epigenetic standpoint, but your child will now be born into a household that in theory is already modeling better habits, right? Because in order to get your own health in shape, you had to do X or Y or Z. So now your kid is born, you're already doing X or Y or Z, so you're going to keep doing it, and that's what your kid's going to be exposed to. And then when your kid is 6 and 7 and 8 and starting to create their own ideas of the world, they have this great role models in front of them to learn from. So, people ask me like, how would I sort of fix the obesity epidemic? That would be the place I would target the most, because I think, well, not the most, but because you have to fix the food industry, you have to fix exercise availability and affordability, you have to do it all. But if we don't fix the epigenetic and in utero sort of genetic imprinting or hypothalamic imprinting aspect of the disease, doing the other stuff is really going to just be sort of, I don't know what the right word is. It's sort of like trimming a bush as opposed to like really pruning it and maybe that's not the right analogy, but it would be a drop in the bucket. Let's just say it that way. Like, you have to, if the genetic and epigenetic pressures are so strong, fixing the food isn't going to be enough on its own, or fixing exercise availability in and of itself will not be enough.
And that, so scientifically, like I'm completely and totally on board with everything that you're saying. And, epigenetics, it is newer. It's again, I'm old enough, probably 15 years ago, epigenetics was really starting to take off. There was a lot of work being done over in Germany, on this stuff. And, it's, unfortunately, it's become so much of a marketing term now. It's like, oh, get your MTHFR, and, we've done that in our household for our own personal reasons. And like my wife was asking me, like, can you decipher this for me? And I'm like, I'm looking through and it's just like he, this is interesting, but it's hard to take action on because everything is still so speculative. Like they're bulimically throwing everything out there. So, but it's associated with everything. It's like high sensitivity CRP. It's like, do you have cancer or did you step on a nail? It's like, I don't know. You've got inflammation. It's informative but useless at the exact same time.
And actually, the word epigenetics is almost becoming like the word or the initials AI, where people toss it around without actually knowing what it means. And they lump a whole bunch of different things into, with AI, there's large language models, there's, what's it called? What's the supervised? There's supervised learning and unsupervised, like all the different types of AI modeling. But people just say AI. And I think epigenetics is sort of the same way, where people just say it and they don't really know, like, is it histone deacetylation or is it like methylation, or what is the actual epigenetic change that's happening, and is it reversible or not? And then does it actually translate into differences in gene functioning? The answers are, we don't know a lot of those things because it's only a 20-year-old field or whatever, 15-year-old field. But it's people use it sometimes, I think, sort of more loosely than maybe they should.
Well,
the examples are exactly where, those are examples, great examples.
And I'm not going to go just like what you stated regarding the food industry and the pharmaceutical industry. It's not like it was done with some sort of intent, but if there's money to be made, people are going to be all over it like white on rice. And here's a huge area, especially with longevity and health span, which are those two terms are becoming absolutely meaningless to me because it's just marketing to make money. And that's part of the crying shame when it comes to all of this stuff. The last thing I want to kind of throw out there regarding the epigenetics. Well, actually, no, maybe we might be opening up a Pandora's box on this. There's also that aspect of timing in the person's life cycle in which things are susceptible to being turned on and off. And you had mentioned like in utero, and that's take your prenatal vitamins or what. Okay, that's fine. Is that even contributing to the problem? Because half of those compounds are artificially derived, or they're not even bioavailable. So why are you even taking them? I had Dr. Sunil Dand on the show, and I was talking about, as a part of this pediatric obesity issue. And like, I've had other guests on the show talking about when they went to medical school back in the 90s, they were taught that children could not get type 2 diabetes. That's when it was still juvenile diabetes and late onset from a terminology standpoint. You throw that all out the window now in 2025. And then you've got, well, it was originally NAFLD, non-alcoholic fatty liver disease. It's now MAFLD, metabolically. So again, all of this verbiage is changing, but like here in the state of Arizona, like I'd mentioned to him, like the youngest diagnosed case that I'm aware of is 8 years old. When you turn the clock back 30 to 40 years ago, it wasn't even a disease here in the United States. And now it's a pediatric condition. But then he brought forward to me, it's even worse than that, that there are newborns that are being determined to have early stages of MAFLD in utero. And so do you have like any because like everybody talks about the weight aspect. Oh, you're kind of chunky, and some people even like go and associate it with being like jolly and like like Buddha. Buddha's a big fat dude who's like spiritually enlightened. But the bigger question is what's going on inside you that you can't see. So as a part of your discussion with parents and a part of your treatment option or a treatment ethos, the type 2 diabetes or insulin resistance, let's turn that all the way upstream to insulin resistance, to MAFLD, to like all of this stuff. Where does that fit in as a part of your discussion with individuals and as a part of your treatment regimen?
Sure. So first, I have to talk a little bit about my failed startup company that was looking at adipocyte-derived exosomes and the microRNAs that were contained in them and how they can cross the placenta and cause mesenchymal stem cells to differentiate into fat as opposed to muscle. So there are babies who are definitely born with metabolic issues that are inherited from their parents that they come out of the womb with, for sure. I hadn't heard, I don't know how they're measuring metabolic dysfunction associated fatty liver disease in those babies, but it wouldn't shock me to hear that they have some signs of that, because I know that they have other metabolic issues. Their lean to fat mass ratio can be off. So not a surprise there. Obviously, when people have one of those comorbidities, excuse me, when people have one of those, like if they have insulin resistance or they have early signs of liver disease or sleep apnea or take your pick, obviously that changes the treatment discussion and again makes things more urgent often. Especially, so what some people don't know is that obstructive sleep apnea, which I think people probably now know about, if nothing else, because they're the commercials for the implantable device that are on TV now for the, what's it called, the Inspire device or something. So there's so much direct-to-consumer marketing about medical problems that they're diseases I didn't even know were that important that are now being advertised on TV. And I was like, I didn't know everybody had plaque psoriasis. Like, seems like the whole world has plaque psoriasis now because, it's being advertised on TV all the time. But anyway, but the point is that sleep apnea, like in kids, it's in adults. I think people, if they know about it, they think about like falling asleep behind the wheel or falling asleep at work or snoring or, being punched by their wife because they're keeping the whole house up or whatever. But in kids, because their brain is still developing, that oxygen deprivation that happens when you have sleep apnea is more significant and can actually lead to more significant and even more permanent executive function or academic function problems, deficits. So, and another thing that people don't likely know is that diabetes, MAFLD, both of those two progress more rapidly in kids than they do in adults. So similar disease progression pathways, but just quicker. So you go from insulin resistance to diabetes in adults, somewhere usually average about 6 years it takes. In kids, it's 2. So, which again, if you think about it, is sort of can be intuitive, because if you're already sick at this young age, it means you have a worse form of the disease than people who get it at 30 or 40 or whatever. So all of those things factor into any decision you make in terms of how to treat somebody, but they certainly provide a greater sense of urgency for me if I'm trying to guide a parent or a patient or both. I might say, listen, your liver tests already show signs of inflammation, and that's not going to get better without weight loss. And for most people, once they reach the level of obesity, diet and exercise doesn't allow them to lose enough weight to reverse those comorbidities. So now let's talk about what you're willing to do. Are you interested in giving yourself a shot once a week? Will you take a pill? is surgery something that's you would consider? So I've always tried to just give people all the information I have about any particular situation and help them make a decision, but not necessarily push them into a decision. Again, unless if someone, someone's on insulin for type 2 diabetes at age 11, I will frankly tell them that they are almost certainly going to need bariatric surgery at some point in their life to reverse that. So you don't have to do that now, but it's something you should know because the likelihood of you needing it at some point is high. And yes, try to control your A1C and do all those things without surgery, if that's what you prefer. But just know that the likelihood is that you will need me at some point. And then I say something, try to be funny about it, like, but prove me wrong.
Oh, sure. No, absolutely. It's like my general statement, like regarding the particular drugs that I'm developing through my company are all towards metabolic cardiovascular and neurodegenerative. And because of all of this lifestyle stuff that we're talking about, there's a clear interconnection in all of those biological pathways, and that's what my company is targeting. But when I go and I speak to people regarding this, it was just like, make me bankrupt. You guys take it upon yourselves where the stuff that I'm working on becomes absolutely irrelevant. But for me, that's a safe bet. I understand human behavior very, very well.
And I used to get up and give talks and say, listen, I would be more than happy to put myself out of business as a bariatric surgeon. I'm telling you all the things you can do to put me out of business so I never get to do another surgery in my entire life. But I know 100% that that's not going to happen. Like, I can tell you the things that, we can do to put me out of business, but I just know society is not, it's ain't happening. But it is interesting. I mean, I think the things you're looking at are obviously, I like to make the joke sometimes about the movie WALL-E. I don't know if you ever saw that movie, WALL-E. Where
the robots, Disney film, yeah.
Yeah, and then they end up being like this group of people who are living, like who basically live on a couch and never move, and they have like no bone density and whatever. And I make that joke. I said, there is a possibility that we could figure out how to do that medically, right? We can use silencing RNAs that like basically prevent all of the bad things that adipocytes send around your body, or whatever. It is theoretically possible we could make that happen, but would anybody want to live that way? Like what? Like why would we? But anyway, it's the field's not going away anytime soon, and I think there's some data that show that obesity rates might be slightly dipping right now, and it is probably due to the GLP-1 medication availability. But we'll have to see. We'll have to see what it could also be just a statistical blip, and that 5 years from now it's right back where it was.
Decoding Health is proud to announce that it has established a partnership with Unicity International, the healthcare intervention company on a mission to make metabolic health doable and accessible for people everywhere. Through this partnership, each and every one of you Decoding Health podcast viewers will get special access to Unicity products. This includes wholesale pricing along with a money-back guarantee. Ready to learn more about how to reclaim your metabolic health? Click on the link below and get introduced to the Feel Great system, a scientifically proven approach to boosting the body's natural GLP-1 production. Stop this GLP-1 receptor agonist craze and give this all-natural approach a try and start your metabolic health recovery now. But there's a couple of things here. You just opened up a Pandora's box that I need to kind of step into it, because we started off this conversation with define for me what obesity is. And what I'm seeing from the data is, even though the number on the scale has dropped for these individuals, because of the level of sarcopenia, you're actually becoming a skinny fat, which is a legitimate argument that can be made regarding this. The second thing is the rebound that is occurring on is very real. And when you go and you look at somebody who's lost, whether or not you subscribe to 40% of that weight or 60% of that weight is due to sarcopenia, when that wrath comes back and you gain all that weight back, metabolically, you're worse off than where you started. And that's a part of the concern on this. And so,
That's an interesting. So, sorry, I didn't even
No, no,
interrupt
no,
you.
no, no, no. Please comment. That's the whole point of this show. We're talking here.
Yeah. No. So some of what you said is so. Bariatric surgery has been around since 1991, and all of those patients have a ton of lean mass loss, and basically none of it is symptomatic. And the concern over lean mass loss with the GLP-1 medications, to me, is kind of like you guys aren't paying attention to what we've been doing for the last 30 years, because we already have lots and lots of data on surgical patients who've had lean mass loss, but haven't suffered from that. And then what in kids anyway, and I can't say this is for sure true in adults because I don't know the data as well as I do in kids, but in kids, their beneficial effects of weight loss surgery, bariatric surgery, metabolically, persist after weight regain. So there are 15-year data now from kids that show that even in children who regain their weight, they're better off medically and metabolically than they were before their surgery. So the point of that isn't to say what you're saying is inaccurate. It's to say that it's probably or potentially different between surgery and medical or GLP-1 related, or even biagonist or triagonist related weight loss. So it's just to say that the science isn't quite as clear cut as some of the people out there like to make it. And I think that's sort of, honestly, that's the truth about obesity in general, is that we still understand so little about it. Like we think that 3 agonists is better than 2. I don't know if that's going to be true or not. 2 is better than 1. So one of my favorite things in the biagonist world is that tirzepatide, which I'm sure lots of your listeners know what it is a GLP-1 agonist, and then a GIP agonist, gastrointestinal peptide agonist, made by Eli Lilly. Amgen has a drug called Maritide that is a GLP-1 agonist, just like tirzepatide, but it's a GIP antagonist. And it has weight loss that's basically the same as tirzepatide, at least in clinical trials. And as a scientist, I think to myself, how on earth can that possibly be? How can you have an antagonist and an agonist that basically do the same thing? And there are some scientific explanations, resulting fatigue and other things that and maybe they're working through different mechanisms or something like that. But I only bring that up to just show that there's still a lot to learn. We still don't know what we're doing in large part.
And I say this all the time, you don't know what you don't know. And again, I'm throwing all of these things out there as questions just simply because I show me the clinical data. Like I even had a guest on earlier today that I was interviewing, like even the microdosing of this stuff. And I'm like, okay, that's fine. Show me the data that supports this. Like, is this medicine or is this entertainment? Like, I don't know what this is supposed to look like because this has never been studied before. And maybe it's great. Like, I don't know. And you just, you were talking about the dual agonists, and now we've got the triagonist in the form of retatrutide, which is coming forward, still in clinical trials. But there are people in the longevity space that are using RUO versions already, which just blows my mind regarding all of that.
Or compounded versions. Like, I don't even know how you can get a compounded version of a medication that doesn't have an FDA approval yet. Like, I don't get it, but people do. Somehow it's out there. You know what I mean? I've talked to people who are taking compounded retatrutide, and they say it's great. And I'm like, how do you know what you're getting? Like, who is who's monitoring any of that stuff. But
Well, yeah, and even the legitimate compounded versions, because the semaglutide and tirzepatide, those are still available compounded. But there's now studies that are coming forward from the NIH, and the FDA has even offered guidance on this, just simply because the statistical numbers are there, and you have to the numbers are the numbers. It's just that's what it is. And if you are taking a compounded version of a GLP-1 receptor agonist versus the name brand, you are 235% more likely of being hospitalized. We're not talking about going into, admission into the emergency room. We're talking about, no, we have to put you into a bed, and I'm sorry, you might be losing your gallbladder. That's the worst case scenarios, but you don't know where you're going to fit on that Gaussian, honestly, you looking at me, tell me where I'm going to fit on a Gaussian distribution for anything.
yeah, no,
I've got
I'd like to make that. I also like to make the point about sort of the bell curve, and like, because especially when I'm talking about like sort of blaming or not blaming, let's say shaming other people for their weight issues, because people do it inadvertently sometimes when they just say, you should just do X because that's what worked for me. And I try to explain to people that what worked for you really has almost no predictive value of what works for someone else. Yes, if there were like 150, 200 of you, and we put you on a bell curve, and then we treated all 150 of you the same way and figured out who did what, and maybe we can use that to help guide others. But you as an individual, if you succeeded on whatever, take your pick, has almost no bearing on your neighbor or your, unrelated person. But yeah, I like to try to tell people that everything we do in medicine, for the most part, is based on what the average, quote unquote, patient, how they'll respond. And unfortunately, that one individual may, they may be an outlier to the left or to the right on the bell curve, and we just don't know. And so, so that's why sometimes I'm more than happy for people that, let's say, do lifestyle changes, because if they're in that, far right side of the curve where they actually can lose a lot of weight from just doing that, do it. Like, that's great. Like, save yourself the other headaches of medications and insurance and complications and all that stuff. But the reality is that, 97.5% of people won't have that response. So I think, unfortunately, we live in an era where medicine, I think, is at its like lowest point in terms of trust from people. And I think it's probably not just medicine, it's probably sort of science in general, or at least health science. So we're fighting, you were sort of talking about this before, we're fighting all these different voices who are trying to get people opinions. And they might be online companies trying to sell you epigenetic kits, or they might be, the HHS secretary. It could be all kinds of people who are giving you different information that you're trying to piece together as an individual. And unfortunately, it's not as common that you're getting that information from your, primary care doctor or some trusted medical source. You're generally, it's like one of the good and bad things about the internet. People can do their own research and figure out what they want to do, but sometimes they just don't know the quality of the source, where it's coming from.
Well, the quality of the source, and it goes back to that whole aspect of it, like, we don't know what we don't know. It's just, there's just not enough information to be able to make any decision unequivocally, like left or right on this. It's just like there's so much stuff, like, in terms of data that I turn around and see, and it's like, I understand why they came to those conclusions, but it's simply because in that manuscript they had to come to some sort of conclusion. But
Publish a conclusion.
Absolutely. And, I go and I look at the data, and there's often times in which, like, if I was the reviewer on this, I would have significant concerns, regarding this. And maybe there were, because we never see those communications, in those email threads. And so, again, like, even as a card carrying, scientist out there who's still active, in the field, like I do this podcast for fun. It's it's really hard just figuring out, like, what is it. And I'm Andrew Huberman. I'm sure who he is. He was on Bill Maher. And Bill Maher, like, asked him, like, what do we know in terms of science? And Andrew Huberman gave his honest opinion. Bill Maher thought we knew 50% of what it comes to medicine. And Andrew Huberman was just like, nah, it's like 10%. That's all we really know. And, I'm more in alignment with Andrew Huberman because I've seen a lot of this stuff. And maybe it's just the simple fact that, for a good reason, we can't lock human beings in cages and go and study them in controlled situations, and, rightfully so, and cloning people, blah, 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 blah. It makes, because of that individuality, the appropriate being able to study the specific. And so everything has to be on a population base. And that's good. And then that's bad at the same token too. So, kind of getting back, I'm loving this philosophical stuff that we're talking about,
Yeah, we haven't really gotten into the deep details but I think the philosophy is just as important, if not more so, to be honest.
because it explains the rationale behind the thought process. Because a lot of people, they see the decision that's made, and it's just like, and a lot of people are very self-serving. Well, that doesn't benefit me, so therefore I'm going to turn around and be against it. But you don't understand where that outcome was derived from. And if you understood that entire process, you would realize that this is the best decision of just a really crappy situation, to be honest with you. When you're treating sick people, there's nothing wonderful. Like, when you go in and meet with, like, a family that's desperate with a sick child, do you sit there and get the warm and fuzzies in your stomach regarding it? It's like, I'm assuming there's going to be a lot of, like, this really sucks, and I'm going to do what I can to help you. But I'm going to kind of throw it out there with, like, the last question, like, the level of success that you're seeing, because there is that responsibility from the patient side. And, like, I don't care if you're taking a shot or exercising your ass off or getting, a bariatric surgery. If you still continue to make just crappy choices. And again, when you're talking about pediatrics, it's not their choices, it's the parents' choices that are influencing them. Like, what does this level of success or failure on the reverse side of that coin, what does that look like in reality?
Yeah, so in the adult world, about 20% of patients who get bariatric surgery either don't lose enough weight or regain their weight. And in the pediatric world, it's lower than that, although we don't have as many patients to make that claim from, because we've only been doing it for 20 years, and only about a couple thousand kids a year get bariatric surgery, as opposed to adults where it's 100,000 a year. But the most children, anyway, or families, let's say, are unlikely to go through something like surgery and not try to make the right changes both before and after. Adults, I don't want to get into the adult psychology business, because adults do lots of other things that don't make sense to me. And so I am sure there are some people who get surgery and then either self-sabotage on purpose or self-sabotage not on purpose. But in kids, it tends not to be that way, because, again, most parents aren't going to sign off on letting their kid get general anesthesia and then go out and buy 2-liter bottles of Coke and put them in the house. Like, it's just unlikely to happen. Although there are times where I've had kids who did better once they got out of their parents' house. When they went off to college and were really able to buy their own food and live on their own, they actually did better than when they were living in their parental home, which is good, but also somewhat sad to think about. But, so there are, what does it look like? So what I try to tell patients, and I feel strongly that this is the way we should all sort of do it, is like, if you're struggling, come back and talk to me, because we have other alternatives right now, especially now with these medications. Like, you might get surgery, and let's say some traumatic thing happened in your life and you're stress eating, then we can get you hooked up with a psychologist who can help you deal with that. Or if you're, food insecure now because of, whatever, you lost your job or your parents lost your job, and the only you can afford it to eat is, the ultra processed food that's at the carry out on the corner. There are things we can do to try to help. And some patients need medication after surgery. And that's okay too. So I try to make sure people understand that it's a chronic, complex disease that requires a lifelong attention, and perhaps any or all of the modalities that we have to treat it. And I try really to take the sort of judgment out of it. Like, don't let anybody tell you that medicines are GLP-1s are an easy way out, or surgery is an easy way out.
They do market it that way, just for the record.
No,
It's
I know.
pretty, yeah.
I know, but it's not easy. Neither of them are easy on the patient. They're hard to adjust to, frankly. But they help you make better choices, for sure, because they do take away hunger and food noise and things like that. But I just try to, especially for the kids, I try to tell them that this is just the hand you were dealt. You got to deal with it. And let's not worry about the past. Let's worry about the future. Here are the options to get healthier. Let's start on some, or more than one, or whatever you're ready for. And just know, whatever option we choose, there are other options. So you're not like, there's no case that's untreatable or that can't be helped. So that's sort of my philosophy. And I think that it works for people, because people want hope, and usually they want help. So, I try to just sort of lean into that. And, yes, I've seen some people sort of either self-sabotage or not stick to the program or whatever. But I usually, again, attribute that to either a life stressor or sometimes biology, honestly. Like, I think we don't know. I mean, talk about things we don't know about. We don't know jack squat about the brain. And so, like, if your brain is telling you, even after you've had bariatric surgery, that you should go out and eat chips and soda and stuff like that, I don't know why your brain is telling you that. And it might be, again, it could be ultra processed foods.
Food addiction. I've had specialists on the show regarding that. And that's, from a societal standpoint, like if somebody said I'm an alcoholic, everybody would respect that. If somebody came to you and said, hey, guess what? I've got food addiction, a lot of people would get laughed at. It's just because it's not taken seriously. And no, there are people who, you can be addicted to anything. You can be addicted to exercise and take it to an extreme where it's just bad. So,
and a lot of addiction, sort of, I wouldn't call it addiction medicine, but replacing an unhealthy addiction with a healthy addiction is sometimes what has to be done for people with addictions, right? And and so I think that one of the issues with food addiction, which is a whole other topic for another day, is that this happens, again, more so in the adult world than in the pediatric world. But the people who are like food addiction, I don't want to say enthusiasts, but advocates, or whatever the word is, they just think everybody has food addiction. And so they're not willing to say, yes, there's probably a subset of people with obesity that have food addiction, but there's also a subset of people with obesity where it has nothing to do with their dopamine receptors in their brain and the food that they eat. It's some other mechanism that is unrelated. And again, I come at it from the pediatric world. I can tell you there are very few pediatric patients who are true food addicts. There's some, but it's a small number compared to people who are just biologically driven to gain weight but aren't addicted to food.
This message is for athletes, CEOs, and high-level entrepreneurs only. So if you aren't one, keep scrolling. You've already mastered your field. Now it's time to own the mic. At PS Studios, we do podcast production for you, not with you. From strategy to recording to distribution, our done-for-you service is built for leaders who don't have time to tinker. We partner with elite clientele across the country, producing podcasts that amplify authority, expand influence, and open doors you didn't know were waiting. The leaders we work with don't hesitate. Lock in your call before our calendar's full.
But that comes from that whole concept of time in your life cycle. You know, we as adults, we have a lot of addictions that if a child was addicted to that stuff, it'd be like, wow, there's something really, like if a 6-year-old was addicted to nicotine, I would be like, there's something going on here that we need to call somebody, you know, regarding that.
Yeah, and I think that that's actually one of the reasons why my perspective on obesity in general is different. Is because I see it in a different cohort of people, and you know it's obviously a smaller number of people. Like 15 million kids have obesity, 150 adults have obesity, and most. So just by numbers alone, most adults with obesity didn't have obesity as a child. So it is different. And I do think it's almost, I sometimes like to joke that we should change the name to weight gain spectrum disorder, because weight gain is different for everybody. And it's different depending on when you get it, depending on why you get it, how you get it. And so we treat it the same because we don't really have any other treatments other than the handful of things that we, behavioral medication, surgery. We don't have a whole lot of other options, but we treat it the same. But I'm thoroughly convinced that it's just a phenotype that comes from a myriad of different genotypes that we just don't still understand yet.
And with that said, I would not argue with you one bit regarding that. Again, back to that general concept, we don't know what we don't know. So let's stop BSing ourselves that we know everything. We're not God. So with that said, hey, Evan, if somebody was watching this and they were like, bam, this is really resonating with me, I hear a dog.
Someone was watching this, they'd be like, that guest of yours is like the worst guest you've ever had because he can't control his local environment. So he can actually get through a podcast without multiple interruptions.
No, it's fine. We're all good. If somebody wanted to find you, where can they find you?
Yeah. So hopefully you can hear me. There are a couple ways. So my website is www.obesityexplained.com, which is also my Instagram handle and my YouTube channel. I'm easy to reach through any of those. But actually, if people wanted to email me, my email is evan.nadler at my initials, which is epnmd.com. And believe it or not, I'll answer you because it's just how I am.
Gotcha. No, really appreciate it. And all of those handles are dropped down below. So if you guys have any questions, make sure you reach out to Dr. Nadler. Leave a comment. If I can't answer it and I need to turn around and ping Evan, I'll be more than happy to turn around and do so. So ladies and gentlemen, I hope you guys found this insightful. Evan, we do need to set up a phone call to talk about microsomes and exosomes and siRNA.
Yeah. No, I think it's all super interesting. The science of it all is fascinating, and happy to set up that call. And I'm also happy to come back on the show anytime and do a Q&A with listeners who call in and ask questions.
Oh yeah, I would love to be able to do something like that. Just waiting for us to reach that critical mass in which it would be worth our time and stuff. But nonetheless, that would be really fun to do a live event. But nonetheless, hey, Evan, Dr. Nadler, really appreciate you taking the time to be on the Decoding Health, sharing everything with our audience. I hope you guys got something out of it. Again, comment, share it with a friend. Obesity is real. Childhood obesity is real. If you guys are just scratching your heads, spinning your wheels, this is another approach. Again, Dr. Nadler, he's agnostic regarding the approach. Let's just get everything onto the table and pick and choose.
Just here to help. Just here to help.
Absolutely. All right. Thanks, everybody. And we'll catch you guys again on the other side.
Okay. My pleasure. Thanks again for having me.